We're going to introduce Chapter 16 by looking at a few pages out of Chapter 4. We'll introduce national health reform by looking at other countries, and in Chapter 4 that summary is just the pages 118 to 122, just a few pages that I'd like you to read. We'll look at Canada, Germany, Switzerland, United Kingdom, and the United States. In Canada, it's a single-payer health system. So that single payer is actually the government running the insurance system, national health insurance. In Canada, the providers remain independent. They are not part of the government. They are not employees of the government. But they work for the patients and then get reimbursed by the national health system. Administration does vary a little bit by province and territory, but it's reasonably consistent. Certainly across all of the provinces and territories, there are no copays when you go in to get services, and there's no premiums paid by the insureds. This total insurance is not paid for by premiums from the employees, but through taxation. You generally can't opt out of the national health insurance and into a private insurance scheme. A motivation to do that might be to avoid wait to access providers or to get a different set of providers. Quebec is the only exception. In Quebec, you can opt into private insurance and out of the national health insurance system. Now, there is no financial rationing, right? No copayments at point of service, so you'd expect quite a bit of moral hazard if everything's free. And instead of rationing by requiring premiums, what they do is they ration by wait time, because there are only so many providers, and if everybody wants services, people have to get in line. Because nobody's going to opt out of services because it costs too much. So particularly for elective services, you could wait months, possibly even years, even a year for an elective service. In Germany, we have socialized insurance. That means there are insurance companies, or what are called sickness funds, and they are not run by the government, but they are run within single payers within districts of the government. So in some geographic district, there will be a single sickness fund that provides socialized insurance to the people who live in that district. Again, providers are independent. They don't work for the government. They just get reimbursed by that insurance company, that sickness fund. It's financed by mandated premiums paid for by employers and employees. So this is an employment-based system. In fact, it goes even further than our employment-based system, because former employers are required to pay for unemployed. So if I'm an employer and I have to have some layoffs, I have to continue to pay for insurance for those employees until they find a new job. The sickness funds are not-for-profit insurers, one in each district, and those sickness funds coordinate the collection of the premiums and payment from the employees and the employers, and they pay the providers. There are small copays to access care, and in Germany there is a private insurance scheme that is there as an option, and so you can opt out of the socialized insurance and into private insurance. In Switzerland, we have what's called a managed competition framework. That is, there are health insurance markets that are administered by the government and managed by the government. Coverage is mandated. Each individual has to buy insurance. Insurance is private. It's not a government-run insurance company. There are lots of insurers, and each of those insurance carriers can offer some subset of 70 standardized plan designs. And so that, just like the Affordable Care Act creating the metal levels to make it easier to understand and compare plans across insurance companies, in Switzerland there are 70 standardized plan designs, so it's easier to compare one plan to another. And it's not the sky's the limit in terms of how things vary. There are 70 standardized designs. Again, providers are independent. They don't work for the government or for those insurance companies. The insurance is actually privately paid by the individual. It's not tied to employment, so that's different than Germany. Premium subsidies come from the government to help cover the poor. The insured individual chooses the copayment level. That is, they pick which of those 70 standardized plan designs they want. So how big is the deductible, things like that. And then one thing that's really interesting about Switzerland, and part of what makes it managed competition, is that the government redistributes premiums across insurers based on the risk mix of enrollees. So if I'm a plan who gets a set of enrollees that happen to be really sick, and another insurance company gets a mix of enrollees that happen to be relatively healthy, the government will take some of the premiums from that other insurance company and transfer them to me, since I got bad risk selection. In the United Kingdom, they have a single payer system, and that payer is the government. So it's a national health insurance program. But more than that, the providers actually work under contract to the government more on a salaried basis. And so they contract with the government to be part of the national health system. So the providers actually work for the government and are paid through the single payer system. Each district within the United Kingdom gets a global budget. So these providers are not paid fee for service, they're paid salary out of that global budget, and that budget comes from general tax revenues. And the district manages care in their area. They delegate some of that management to the general practitioners, and those general practitioners manage primary care and some of the specialty and outpatient hospital budgets. So the United Kingdom is very different from the other countries in that we've got this national health system that is a group of providers working typically under a salary basis for the United Kingdom and that single payer system. In the United States, we have elements of all of these designs depending on the segment of population that we're talking about. So, for example, our Medicare and Medicaid programs are kind of like Canada's single payer system. There's one insurance company, and it's the government, and the insurance is financed through taxes. In the case of Medicare, it's financed through payroll taxes. And in the case of Medicaid, it's financed through general tax revenues. Although within Medicare and Medicaid, you'll learn when we talked about Medicare and Medicaid, you learned that with Medicare Advantage, there's some shifting to private managed care under those plans. Employment-based coverage in the United States is still very prevalent. That's kind of like Germany, except that the mandate isn't there yet. There is an employer mandate under the Affordable Care Act. It hasn't gone into effect yet. It's been postponed several times, and you'll learn more about that when we do the Kaiser Family Foundation summary of the ACA. Health insurance exchanges under the Affordable Care Act, and here we call our local Minnesota one MNsure. They're kind of like Switzerland, the managed competition, where the individuals go out and buy insurance coverage under the mandate. And then finally, our Veterans Affairs benefits, our VA benefits, are similar to England with providers that actually work for the government and financing on a global budget basis from the government. So you can see we have lots of different things going on and a patchwork of different kinds of systems in the United States. Most payer systems still reimburse on a fee-for-service basis rather than managing global budgets. The Veterans Affairs is an exception to that. Although we're moving more toward global budgets as we experiment with bundled payment and shared savings. And we've talked about those new reimbursement methods a couple of times.